caveat for our Q&A for today's presentation. Our topic today is really meant to be focused around industry education. It's not product focused. And we do have multiple representatives that I want to say, welcome to, that are from our EMD's product lines, including clients representing Solution Series, Medisoft, Lytec, Practice Choice, and Practice Partner. We're also pleased to welcome a number of our VAR partners as well as newcomers to EMDs. So we're not going to be focusing specifically on product today. We're going to be focusing on the topic of ICD10 and strategies that you can employ in your practice, regardless of which solution you're using, to help you prepare for the end of the grace period. So if you do have a product-specific question, please go ahead and submit it. We will get that answered for you. It will be answered offline. You can use the Q&A tab here, or you can send it to our info@emds.com email address. That's emds.com. And I will route them to the appropriate person and make sure those questions are answered for you. If you do that, please specify what product your question is in reference to so I can make sure that I route it to the right group of people. Okay, so I just wanted to make that clear that we're keeping this focused on industry education today. On your screen, you should see the slides for today's presentation. If you are interested in viewing this in a full screen mode, you can click on the two arrows in the upper right-hand corner of the slide screen, and that will expand it out for you so you can view full screen. Okay, so that does it for my housekeeping notes. Now I'd like to turn it over to Tracy to talk about ICD10. Tracy is an account executive with EMDs, and she's been working closely with our clients on their revenue cycle management, and that includes the ICD10 coding. And she has a wealth of knowledge in this area, and we're really pleased to have her with us today to talk about this important topic. So without further ado, I'm going to pass this over to Tracy to get started. Tracy?
Allison, you can hear me? Okay.
I can hear you.
Great. Welcome, everyone, and thank you for joining us this afternoon. I hope you all are doing well. So we're going to talk about how to prepare your practice for the end of this ICD-10 grace period, and what does that mean to us. So today we're going to go over the ICD-10 grace period. We're going to talk about preparing your practice with KPIs, your expected denials, commonly seen mistakes throughout the industry, improving clinical documentation, and go through a small checklist at the end, and then we'll talk about questions and answers. So as of October the 1st, 2016, will mark the end of a one-year grace period that allowed unspecified ICD-10 codes on certain physician Medicare claims. The grace period was a joint initiative between the Centers for Medicare and Medicaid and the American Medical Association, created to help ease the transition from ICD-9 to ICD-10 for physician practices. The end of this transitional period could be a rocky one if coding professionals and providers neglect to prepare for it. So now that you've made the switch to ICD-10, you can look for opportunities to analyze your progress. By tracking and comparing key performance indicators, or also known as KPIs, you can identify and address issues with productivity, reimbursement, claims submission, and other processes. I'm going to go over a couple of these KPIs. I'm going to give a brief description of each of these that I've listed. So the first one I have here is claims acceptance rejection rates. This is the percentage of claims accepted or rejected. A lot of times during our monthly meetings we go over our clean claim rates, and when you do this, this is a good opportunity to take a look at those rejected claims. The next one is your claim denial rate. This is the percentage of claims accepted into the payer's adjudication system that are denied. Consider keeping authorizations and coding denials separate when trending these edits. Again, this is when it hits the payer's adjudication system. The next one is the volume of coders' questions, especially in your specialties. This is the number of records your coder is returning to the clinicians with requests for more documentation to support the code selection. If you're seeing a lot of this, you really, really want to take a look at why the coders are having to send those, sending it back for more documentation. The other one is another opportunity is the use of unspecified codes. What is the volume and frequency of unspecified codes being used? I just did this for all of my clients, and I was quite surprised to see how many physicians are still using many, many unspecified codes. So it's really important that you take a look at that. Moving on to medical necessity pass rate. This is the rate of acceptance of claims with medical necessity content. And of course, take a look at your payer edits. This is the number and reason of edits required by payer. If your EHR or PM system have edits in place, these are usually built around payer rules. This is right before your claims are being released to the clearinghouse. This is kind of a scrubber system. If your systems do have that in there, this is an opportunity to take a look at what those payer edits are. One of my clients in New York, we look at GHI. We have a specific edit firing for them that if the patient's over the age of 19 and they're trying to bill a well visit, the system will generate and let them know that they cannot bill that. Your clearinghouse sometimes are built around that as well, so make sure that you're reviewing those edits. Is there anything that you can do to correct those edits in your offices? You don't have to track all the KPIs I've mentioned, as some may not be practical or relevant for you. But even small steps to identify and resolve issues can get you on the road to higher productivity and more timely claims processing. Once you've identified the KPIs you will be tracking or trending, establish a baseline for each one, or a point of comparison. For purposes of assessing your ICD-10 progress, you will want to compare KPIs from before October 1st, 2015 transition date with KPIs from after the transition date. This pre-transition of KPIs will serve as your baseline. If you're a provider in a small practice, you may not have routinely used or tracked KPIs in the past. Work with your billing and coding staff to see what data is already available in your system. Or you can also check with your clearinghouse, third-party billers, or your system vendors to see what data you can extract. Finally, track your KPIs, which will help you detect problems and identify opportunities for improvement. Reevaluate those KPIs on a regular basis as you refine your processes in your offices. The CMS website, they also provide a fact sheet focused on KPIs to help you better understand how to analyze and track your ICD-10 progress. So this fact sheet includes a list of KPIs that might be helpful to your practice and can be found on their website. But also I recommend looking at, making sure that you're getting the CMS bulletins or utilizing your AACP or MGMA websites. These really help coders with blogs, different coding questions, things like that. So if you're not already a member or part of those sites, take a look at them. Next, we're going to go into expected denials. There's different denials that we are seeing. I'm going to go over the logic-based denials first. This denial occurs when the ICD-10 or CPT code does not match the corresponding ICD-10 code. Example of this is your carpal tunnel syndrome now specifies left to right. So you're going to want to make sure that those diagnosis codes are specifying the left to right. Coders will need to pay close attention to diagnoses that specify laterality to avoid denials. Very, very important here. The other one is for denials for invalid codes. The number of codes that are added or deleted will continue to increase. As per ICD-10 Coordination and Maintenance Committee, to date, there are 1,900 new ICD-10 codes proposed for October 2017 release. Of that number, there are 313 deletions and 351 revised codes. Make sure your EHR and PM systems are updated regularly and edits are put into place to prevent denials for invalid codes. So we gave an example here of an R68.89, which is other general symptoms and signs. This is one of those excluded ones that will be coming forth. So make sure that your doctors, your clinicians are not using these unspecified or deleted codes, I should say. Again, update your PM system, your HR PM systems, and educate your clinicians. Another denial that is, of course, we're going to see is the denials for unspecified codes. In ICD-10 code system, there are more specific codes than those currently available in ICD-9. Payers will more likely to deny any unspecified codes that are reported. We gave an example of a TA 8.9. This is a complication of surgical and medical care, unspecified subsequent encounter. It needs to be more specified. Assess your denial trends for unspecified codes and make necessary coding changes. We should be in the habit of doing that now, or should have been doing it. If not, this is the opportunity to do so. Also, for your denials for unspecified codes, make sure you're checking your LCDs and your NCDs, your local coverage determination or national coverage determination. Practices will need to absorb this information. Make sure that what you're billing is a payable diagnosis and it is part of the payable portion of the specified code. Okay. Okay, we're going to go over diagnosis-related denials that we've been seeing. The first one we're going to talk about is the claim adjustment reason codes. And we're also going to go over the reason adjustment reason codes. These are used to explain payment adjustments and remittance advice transactions. So your claim adjustment reason codes identify why healthcare claims or services are not being paid at submitted charges. And then your reason adjustment codes provide supplemental information about the adjudication of the claim service. So we've provided some examples here, and I'll go through and we'll actually go, these are your actual denial, your remittance codes, remark codes, but we also went through and gave some examples for those. So the first one we have is the diagnosis inconsistent with the patient's age. Number 10 is the diagnosis inconsistent with the patient's gender. I'm sure all of you, as myself, we went through ICD-10 change, this became a huge denial for us in making sure that we had the specific gender or the patient's age related to that diagnosis. So let's go and look at some of these. So as we talk about CO9, diagnosis is inconsistent with the patient's age. Insurance code editor detects inconsistencies between a patient's age and any diagnosis on the patient's record. For an example, a 5-year-old patient with benign prostatic hypertrophy or a 78-year-old patient coded with a delivery. So when we move to the ICD-9 more specific codes, it specifically states newborn ages is 0 to 28, pediatrics ranges from 0 to 17, for newborns is 0 to 28 days, pediatrics ranged from 0 to 17 years, adult ranges from 15 to 124. And then, of course, maternity was the ages of 12 to 55 years old. To prevent these is, again, you're looking at your claim scrubber or your clearinghouse edits. And then we're going to move on to diagnosis is inconsistent with patient's gender. Insurance detects inconsistencies between the patient's sex and any diagnosis that's on the patient record. A male patient with cervical cancer, C53.9, or a female patient with a prostate hypertrophy, N40.0. In both instances, the indicated diagnosis with the stated sex of the patient can't be billed. Therefore, either the patient's diagnosis or sex is presumed to be incorrect. So make sure that we again are looking at those diagnosis codes and what they're relating to the proper gender. CO11 is another common denial that we see. It's diagnosis inconsistent with the procedure. He gave an example, we gave an example here, for routine pulse oximetry testing with absence of sign or sign symptoms suggesting desaturation is not covered. Refer list of billable codes for the suggested change. And again, I mentioned the local coverage determination. Make sure you're looking at your local coverage determinations, your medical policies. What are we able to bill and what we're not able to bill? Non-covered services not deemed medically necessary. There can be two scenarios where payer can deny the claims with denial code CO50. CO just means your contractual adjustments. The payer denied the claim at the acceptable diagnosis as per the policies not billed with the procedure, or payer denied an E&M service as not deemed not medically necessary. For your corrective actions, take a look at your payer policies. Review the documentation. If the documentation supports, resubmit the claim with the correct diagnosis. And scenario 2, keep an eye for your Medicare issued your prepayment request for documentation for the following inpatient. These listed here, they will request that documentation, so make sure your documentation is in place. Whenever medical necessity denial comes for E&M services, documentation should be submitted with that claim. Another remark code or denial rate would be 167. This diagnosis is not covered. Diagnosis not payable as principal diagnosis, or the diagnosis not payable as per the local coverage determination. Example of this is the manifestation codes describe the manifestation of an underlying disease, not the disease itself, and therefore should not be used as a principal diagnosis. We gave an example of anemia and chronic kidney disease, billed as a primary diagnosis and denied by the payer as not covered. So you want to take a look, of course, at your underlying chronic kidney disease. Perform those coding audits. The next one we have is diagnosis is not covered or missing or invalid. There can be multiple scenarios where payers can deny the claim with the denial code CO47. Scenario 1 is billed diagnosis is not as per the coverage plan. Scenario 2 is diagnosis is deleted code on the date of service. Scenario 3, diagnosis cannot be billed at the primary position. Scenario 4 is diagnosis is not to its highest specificity, missing any digit. And then scenario 5, any secondary or tertiary diagnosis is missing as payer's policy. Scenario 6, diagnosis does not match with laterality of procedure. Corrective action here is covered diagnosis as per payer's policy should be billed after reviewing documentation. Active and diagnosed to its highest specificity should be billed. Any secondary, tertiary diagnosis requirements should be fulfilled as per payer policies, and appropriate laterality specific code should be billed. Again, review your payer edits. This is where you're going to find the medical policy reviews is where you'd find this information. We're going to move on to improving clinical documentation. So we talk about here is your episode of care, your acuity of disease, the laterality. Again, very, very important here, your laterality, now that they're specifying your right and left, not just with modifiers anymore, but your diagnoses are. The type and cause of a condition, disease, or disorder, your underlying condition, manifestation of your disease, linking of the diagnosis, the causal organism, the relationship of drug, tobacco, alcohol to disease, and documentation of use, abuse, or dependence, and support medical necessity with these physical finding labs or radiological findings. We've provided some of these examples, so the most important parts here is good documentation. Good documentation is the key to supporting services billed on any insurance claim. Review and assist with building structured compliant templates that will improve documentation. A lot of EHR systems do provide for specialties different templates that can be built for you. If your system has that, use them to their fullest. Educate clinicians on how to choose the appropriate procedure and diagnosis. Emphasize choosing the correct procedure and clinical diagnosis and not the first diagnosis on the list. Some EHR systems I've seen have a favorites list. The doctor gets to clicking on that diabetic or hypertension, those common chronic diseases, and they just keep clicking them because they populate in their favorites list. we try not to use those, so, educate your clinicians on this. Incorporate documentation in the physician's workflow is an easy way to assist clinicians and also provide accurate capture of procedures and diagnosis. Look at your workflows. What can we do differently? It is important to audit and review clinical documentation to support medical necessity on an ongoing basis, and as a result of KPI findings. A lot of clients that I work with, we do a quarterly audit. We pull and audit 10 charts, and we have a certified coder that does that. She reports back to me, and I'm looking to see if there's a trend. Is it isolated with one physician, or is it an isolated incident? Clinical documentation improvement can bridge the gap between the clinician's coding and billing system. It also increases and captures the appropriate reimbursement for services provided. While we are assessing your practices, or you're assessing your practices, remember healthcare has moved in the direction of quality of care versus quantity of care. The U.S. Department of Health and Human Services announced by the end of 2016 it aims to link 30% of Medicare reimbursements to the quality or value of provider services. And by 2018, it'll be up to 50%. So with quality metrics in place, patients are now more involved with their care, and they're receiving their documentation during each visit, and more patients are utilizing patient portals. So during this process of phasing out these unspecified codes, take a look at your local payers and look and see if they have offer quality incentives for you. Since these doctors are having to document, use this time to get involved in all quality measures that you can. It's very important that we take a look at this. So as we move to the end, I'd like to go over the checklist real quick and assess your progress. Once you've established those comparisons for your KPIs, now the KPI list on the CMS website consists of probably 15 more KPIs that I went over today. So there may be ones that are more relevant to you, but take a look at that. Get your baseline set and take a look at where you were 2015 prior to October 1st and where you're at today. Do you see a huge denial trend? Are you getting more denials? Are they specific to the unspecified codes? Are they gender related? So make sure that you're looking at that. Address those findings. Once you've identified those opportunities for improvement, develop a feedback system. Improve the accuracy of your clinical documentation and code selection. Check for any system issues, and resolve system problems with payers. I can give an example. When I talk about these problems with payers, I had a client in New York that one of the insurance companies changed software systems. And during that process, they deactivated all of our physicians. So when they adjudicated claims, it denied all of them as non-par. And we didn't get paid on anything. It wasn't something that we had done. It was something that the payer had done. But without trending this and looking at this on a monthly basis, we would not have been able to identify that immediately. And it was a large payer, so it was a large cash flow for us. The other thing is maintain your progress. ICD10 updates take place annually on October 1st, following the same timeline used for ICD9 updates. Be sure to keep all your systems and coding tools updated. Make sure you're aware of what codes are being deleted or added. And also, it's best to compare these metrics with past calendar years by month. There's some seasonality to statistics, and you will want to take into account local issues. Impact to staff vacations, flu season, things like that. Keep those in mind when you're developing these baselines. Sorry. Allison, did you want to, I don't know how we do this.
Sorry about that. I was muted. Yes, thank you, Tracy. So we do have some time now for questions, and there have been a few that have come in. Let me start off with this first one. I have a question about R50.9, D70.9, and D46.9. These are all unspecified, but will they be accepted after the grace period?
I would actually have to look into it because I don't know off the top of my head what those unspecified codes are.
In general, though, the recommendation is that you look for the more specified
That is
code
correct. That is correct.
Okay.
If there is a more specific code for that diagnosis should be used and not using the unspecified code.
Okay. So similar question, and they've actually put in what the codes are. So G47.10 for hypersomnia, unspecified, G47.3 for sleep apnea, unspecified, and G47.9 sleep disturbance, unspecified. As a diagnosis for sleep study disorder. Will these still work? Or again, is the same sort of thing applies if there's something more specific, go with the specific code? I mean,
and again, for something like that, especially for sleep apnea, there's a reason why there's an underlying cause for the sleep apnea. So you should be coding it to the highest specificity.
Okay, great. Are you aware if commercial carriers will have the same October 1st deadline?
I'm not aware of all of them, but they are moving in the same direction.
Okay. And are we seeing, I've heard previously that some are actually even starting now with doing some denials around unspecified. Have you seen that?
I actually haven't seen any more. Mine were, again, the gender and the age. Yes, age specific.
Okay.
Those were the more. And as we're moving forward, it looks like CMS, they've announced the fact that sooner or later, since these doctors are going to be paid on their quality of care, it's very important now to try to eliminate as many unspecified codes, because sooner or later you're going to be paid based on your coding and documentation.
So another question, and I actually have this question for you as well, from Debbie. She wants to know where she can find those deleted codes. So you had talked about the 1,900 new codes, the 313 deleted codes, and 351 revised codes. Where can they go to see that and find that information?
Sure. It is going to be, let's see here. So under CMS's website, there's a coordination maintenance committee that meets, I think, quarterly. And if there's any questions that sometimes CMS's explanations are not really black and white, and it causes a lot of confusion on what the right answer is for it. So this coordination and maintenance committee meets quarterly, and any questions that need to be addressed can be addressed through, could be submitted to them. And this is where I went to find out specifically how many codes will be deleted. Now, specialty on their website will also list different specialties, gastroenterology, orthopedics, things like that, that will be deleting specifically for their specialties. So it's kind of important to kind of look at those. They're zip files. You can download them. They become PDF or Excel files, and you can keep them and use those to help trend or build your templates, things like that, in your EHR systems.
Okay, great. And just sort of a follow-on to that, somebody's looking for the list of codes that are expected to be denied. Is there any resource out there that has put that information together?
CMS website does. There are large files that can be downloaded, and you have to go through them, but there are resources there for you to look at those unspecified codes that will be challenged starting October the 1st.
Okay.
And a lot of times your clearinghouse, if they're built, if they're, let the clearinghouse work for you. When we hit that button to submit to the clearinghouse, it scrubs that claim before it actually goes to the insurance adjudication system. So what it's going to do is scrub for those particular, those, like we talked about, CO11s, the gender rule. it will actually scrub it before it even gets to the adjudication system for you to fix. So talk to your, if you have the clearinghouse, talk to your clearinghouse and request your denials that you've received from the front end. And that will help you also take a look at what needs to be, what you need to educate your staff on.
Excellent. A question here. So in general, will there be some unspecified codes that are accepted if there's truly no other information for more specificity?
Yes, and it did state that there will be some codes that just have not. So as they're going through and adding more codes, that's where that's why I say it's important to keep updated on all these deleted codes or the additional codes, because those unspecified codes that you're talking about, but that may not have any higher level of coding to it, those are going to be transitioning out. So keep an eye. They usually do it, I think, at the end of September, 1st of October every year. Those codes will probably be, sooner or later be gone, but for now they may be still in existence.
Okay. And so we have a question from Angie asking if you can review a little bit about initial and subsequent visits. I don't know if Angie can expand on that a little bit further, what specifically you're looking for us to talk about. That might be helpful. So Amanda has a question about E11.9 for type 2 diabetes without complications. I'm thinking, she's wondering if that is specific enough.
I'm actually reviewing, and Allison, I might be able to get back to her like real soon. I'm actually evaluating that myself because I have a client that just submitted 9,000 of those unspecified, that's particular code, and I'm actually investigating now to see what that's going to, after October 1st, how that's going to be accepted into the system, if it'll be denied.
Excellent, great. So Amanda, we can get back to you with a response on that. From Carolyn, some underlying causes are not known until specific testing or referrals are done. So what would the primary care doc use when ordering these?
When they're ordering the test?
Yes.
Yeah, and
they
a
don't
lot
know.
Yeah. That's a really tough one to answer because when we request a CT scan or lab work, we're usually putting the lower of the code, the ICD-9, or the 10 code on there. But a lot of times the insurance company won't pay for that lab or that CT, and then it makes the patient responsible for it. Our doctors are just, if they're requesting the test for a certain reason, they're trying to get trying to code that as high as possible. I understand that you won't know until that lab test or radiological test that comes back. I just don't know. I don't really know how to answer that question because every client I deal with has the same issue when they're trying to submit for those.
So if unspecified codes are going through now, is it likely they will continue? And this is from a pediatric practice.
Repeat that one more time. I'm sorry, Allison.
Sure. If unspecified codes are going through now, so being accepted, is it likely they will continue to be accepted?
So per the CMS website, it is not going to be extended any longer. It will take effect on October the 1st, 2016, when they'll start denying unspecified claims. If there is a higher ICD-10 code to be used, they will start denying them or pending them for documentation.
I'm just going through. So again, if you have a product-specific question, I'm not ignoring you. Tracy and I are not the product folks, so we will direct those. We have multiple EHR users and practice management users on the line, so we are going to route your product-specific questions to the appropriate people and get back to you offline. So please continue to submit these, but we will get back to you offline. We're keeping it more high level right now.
Allison, someone asked about the initial and subsequent.
Yeah.
There is a really good article on the AAPC site, which is it's a coding website, and they have somebody that actually is a certified coder that specifically talks about the initial subsequent encounters and breaks it down in very layman's terms of how to code that. I don't know if I can post the link for you, or I don't know how that works.
Yeah, if you want to send me the link, what I can do is include it in the follow-up communication that goes to all of our attendees.
Okay.
Great. It looks like a few folks are looking for that same follow-up information on E11.9, so we will make sure that we get you that.
Yes.
Yes, so there's been several questions about the slides. These will be available. So you will receive an email after the event that has a link to the recording, so you can listen to the presentation as well as the Q&A again. You can share that with colleagues and coworkers that weren't able to join. And also in there will be a link to a PDF of these slides. So you'll have them as a reference point, as well as the resources that we've been talking about. We'll include those links as well. Another question here, what about codes like L73.8 other specified floccular disorder? Is other in the same category as unspecified?
Hang on just a second. What is it, L73?
Yes, L73.8.
No, for looking at it from my perspective in looking at the diagnosis visually, I don't think that that's going to fall into the unspecified, because it literally is not showing that it's an unspecified code.
Okay. UTI N39.0. Will this be accepted if no organism identified on the first visit?
It's N39.0, you said?
Yes.
So, Allison, let me, can I include that? Can you include that link
Yes.
as well for this?
Yes.
I have it broken down a little bit more so they can see possible other codes to use. But there's several of them, so I just want to make sure that they have a better.
Tremendous. Yes, we'll include that as a resource link as well. Again, there's some additional questions about the removed ICD-10 codes. We'll give you the link to the CMS website where you can find some of that information on the new, deleted, and revised codes. A question from Tina: is the October 1st deadline a DOS or submission date deadline?
It's a data service.
Okay. Okay.